Uh, Good afternoon, everybody. Sunday afternoons are very precious for everyone who are busy people. So we especially appreciate the fact that you have taken time off to be with us today. Thank you very much. I hope you will enjoy today's session. Very welcome to it. And on behalf of the management of our company, that is Toshbro Medicals, I wish you a good day. A little about our company, our organization, Toshbro Medicals. We were established in 1948, just a year after our country got independent. We were into very high technology. That was the need of the day in those days, whether it is process industries, whether it is defense, it is research and development, aeronautics. We were there with high-tech systems to support, and that is the base that we have grown upon. In 1981, we came up with our medical division, and that is the legacy that we have built upon to bring to you solidarity, commitment, integrity, and of course, a committed support system. Today's event is on glaucoma imaging. We have with us eminent people from the industry as well as panelists from Heidelberg Engineering, who's our partner for bringing to you imaging equipments for retina and glaucoma. I would like to hand over this session to Dr. Sathyan Parthasarathi. Dr. Parthasarathi is going to be the anchor for this event. We have with us Dr. Harsha Rao from NN, Dr. Sachin Dharwadkar, Dr. Prasanna Venkatesh, and Mr. Martin Long as speakers. We will be answering any questions that you need answered. You have to just click the Q&A button in your screen and type out the questions you need answers to. And our panel, including application specialists from our team, will be happy to answer them, as well as our doctors will be happy to answer them. And in case we are not able to answer, we'll come back to you individually on a personal level. So thank you very much for being with us again, and I hope you enjoy the session. Dr. Sathyan Parthasarathi, I hand it over to you with a brief introduction. I think everybody knows Dr. Parthasarathi. He's from Coimbatore, Sathyan Eye Institute, Coimbatore. He has trained in some very elite institutions like Johns Hopkins and Baskin Palmer in the US. He's headed very prestigious roles in India, in Arvind, as the head of glaucoma at Coimbatore. And he has won and written many papers. I don't think I can say a lot about him. His work speaks. Everybody knows him. So thank you, Dr. Parthasarathi, for being our anchor today. We're very proud to have you with us. And with that, I hand over to Dr. Parthasarathi. Thank you, Dr.
Thank you, Mrs. Sanas. Thank you so much. It's a great pleasure to welcome you all for this webinar. The basic concept for this webinar is, can this new technology, that is the glaucoma premium module of the Spectralis, can guide us through a proper diagnosis of glaucoma even at the very early stage? And can we have the progression done exactly what is that we want to see? Even at 1 micron level, we can really analyze the details. So that is the Spectralis which can offer to us. So today we have 5 speakers covering different topics, starting from the anatomy, which will be covered by Dr. Prasanna Venkatesh from Trichy. He has completed his MS Ophthalmology and he has completed his fellowship also in glaucoma. He has a very keen interest in glaucoma. So he will be covering on the optic nerve head and also on the macula. And we have Mr. Martin from Heidelberg Engineering. He will be talking to us about the Spectralis, its technology. And we have Dr. Harsha Rao. I don't think he needs any introduction. Harsha is from Narayana. Earlier he was at LVPI. So he is going to talk to us about the optic nerve head analysis from on the basis of the Spectralis. Then we have Dr. Sachin. He is going to discuss about the cases, and I'm going to discuss with you on the macular analysis from the Spectralis. So without much of a delay, may I request Dr. Prasanna to share your screen and talk about the optic nerve head analysis, optic nerve head anatomy and the macula. Prasanna.
Thank you once again, sir, for giving this opportunity, and I would like to welcome all. Am I audible?
Yes, Prasanna.
Yeah. At any point of time, if my voice is breaking,
this also to switch off your mute your mics.
Yeah. Okay, sir. Shall I start?
Yes, Prasanna, go ahead.
Yeah. So good evening, everyone. So I'm just we are just looking at the anatomy of the optic nerve head. The slides have been prepared more of a practical point of view, as Sathyan sir was talking about the Spectralis Glaucoma Module Premium Edition. So all this anatomy theoretical part of which we have already seen, but let us see how practical points we can take from the optic nerve head anatomy. So the objective of this presentation is to decode the anatomy with the workflow of Spectralis Glaucoma Module Premium Edition for better initiation of it. So I'll be using a lot of box slides seen on the right hand side of your screen, because being it a webinar, so this will be helpful in guiding the attendees much better. So then in this slide, I just hope you'll get the point that RP is above the Bruch's membrane and followed by the choroid and then the sclera. As we go through the subsequent slides, I'll try to decode this picture much better. The objectives of this presentation is the true margin of optic nerve head. What is the true margin? Followed by what is the Bruch's membrane and what is the Bruch's membrane opening? What is the Bruch's membrane opening minimum rim width? How it is differentiated from horizontal rim width, and then followed by the alpha, beta and gamma zone of optic nerve head in OCT, and what role does cornea have in influencing the optic nerve imaging. So these will be the objectives. Glaucoma diagnosis, as we all know, it has functional morphology and IOP. So this is more related to only the morphological point of view which we are going to deal with. So what is the true margin or true boundary of the disc? Defining the true margin is very important because we need a true margin. That is where we can work on. So as many people will be knowing about the Cricket World Cup 19, it's all a matter of fine margins. We need to know where we work on with. So clinically, the inner edge of the sclera. So again, there will be a lot of box diagrams which I will be using to establish more easier connection with the audience. So the inner edge of the sclera, as you can see in the green marked line here, the eliciting ring, is identified as the disc margin while performing an ophthalmoscopy or a fundus photography. Whereas in the OCT, the definition completely changes. The termination of the Bruch's membrane, as you can see at the level here, is known as the disc margin. So there are two different terminologies per se. Clinically, they say the sclera's inner edge is the disc margin, whereas OCT defines that Bruch's membrane's termination as the disc margin. So clinical versus Bruch's membrane opening based disc margin, we are led down with two different entities per se, where you can see the red dotted lines is the BMO based disc margin, that is the Bruch's membrane opening, and the green is the clinically assessed disc margin. So now we are left confused with two parameters, but there cannot be two, because if you take the area between these two margins, the clinical margins, that is a clinical disc area, and in the OCT we have the Bruch's membrane opening area. So this study from IOVS said clearly that the clinical disc area was larger than the Bruch's membrane opening area in normal and glaucoma patients. So clearly there cannot be two swords in a single sheath. So which is the true boundary of the disc margin? So this paper by B.C. Chow and et al. Put end to all speculation that the Bruch's membrane opening is the clear boundary which we can define the margin with, because the blood vessels and the axons cannot pass through the Bruch's membrane, and it will serve as a true structural boundary of the optic disc. So we have put an end to all speculation and we go with the Bruch's membrane. So again, orienting towards what is the Bruch's membrane. So the Bruch's membrane is situated between the retinal pigment epithelium and the choroid. So these will be repeated in many of my slides. So just keep the viewers in orientation to the anatomy, as we are dealing with anatomy and applied aspects of it. Moving on to the extension of the Bruch's membrane. The Bruch's membrane can extend beyond the Elsning's border tissue. So this is the Bruch's membrane and this is the Elsning's border tissue. The Bruch's membrane can extend beyond it. If it does, then it's an internal oblique configuration. If the Elsning's border tissue of the choroid extends beyond the Bruch's membrane, then it's an external oblique configuration. So let us apply what we saw in the previous slides. If clinically we examine this particular patient with an ophthalmoscope or a fundus photograph, we'll be ending up with the green line here, and this will be defining as the disc margin. But in reality, the OCT per se, the red line here will show the clear disc margin. Similarly, in this configuration, the external oblique, again here, the green line, that is the scleral ending, will be seen clinically as the disc margin. Whereas in OCT, the red one here, the red line, it will show the definition of the disc margin. So the appearance of Bruch's membrane, histology versus OCT. So again, reorienting, that is the RP is always on top of Bruch's membrane. As you can see in the OCT here, RP is on top of the Bruch's membrane. So the appearance of Bruch's membrane in OCT reveals that the thickness of the Bruch's membrane and the retinal pigment epithelium appears to be more or less the same. As you can see here in the box diagram, the thickness more or less appears to be the same. But in reality, is it the same? No, it isn't. The retinal pigment epithelium is approximately 14 micrometers, whereas the Bruch's membrane is roughly about only 1/3 or 1/4 of the retinal pigment epithelium thickness. It is only 2 to 5 micrometers. It should be thinner. But then why in the OCT do we get a picture? Let's just go back, where the thickness of the RPE and the thickness of the Bruch's membrane here, it kind of seems to be the same, but it isn't. But why is it so? That is because of the principle of OCT. OCT detects the reflectance of bounding surfaces. The Bruch's membrane consists of 5 single layers. Each layer has different reflectivity profiles, which causes the Bruch's membrane to appear thick in OCT, but in reality, it isn't thick. It is thinner than the retinal pigment epithelium. This is an electron microscopic picture of the Bruch's membrane. We have the basal membrane of choriocapillaries, collagen layer, elastic layer, followed by another layer of collagen, and then the basal membrane of retinal pigment epithelium. So moving on to what is Bruch's membrane opening. So this is a two-dimensional picture of how the retinal nerve fibers here enters into the optic nerve. So just orient this picture to a waterfalls. Just imagine that this is the retinal nerve fiber layer coming from here and entering into the optic nerve. So this is a three-dimensional model taken from Heidelberg Academy, showing the nerve fibers to come and enter itself into the optic nerve. So the Bruch's membrane opening, as you can see, this red line here shown, this is the Bruch's membrane, and when it comes and terminates here at the edge, which is shown by a dot, red dot here, that is the Bruch's membrane opening. With the help of Spectralis Glaucoma Module Premium Edition software, totally 24 scan lines are obtained. So we detect 48 BMO positions. You can see there are totally 24 scans which cuts through. That is nothing but 48, one on either side. And we have total 48 BMO positions on the optic nerve. So this is how the scan applies itself, and we get 48 smooth positions as the optic disc margin, the true disc margin. So this is an animation video showing the same, where the green line depicts the internal limiting membrane and the red line depicts the Bruch's membrane, and the red dot here is the Bruch's membrane opening. So the Bruch's membrane opening, as you can see, it's a three-dimensional structure. So on the right hand side, you can see the image. So three-dimensional, superiorly, nasal, inferiorly, and temporally, we get 48 BMO points of the Bruch's membrane opening. So how do we find the Bruch's membrane opening? This is just, these slides are made for targeting basic users, like how do we find the Bruch's membrane opening in OCT? So first, detect the wedge-shaped ending of the choroid. So this is a choroid here which ends in a wedge-shaped pattern, and the Bruch's membrane opening will be seen adjacent to it. So how do we find the Bruch's membrane opening? Another way of finding it is the choriocapillaries cannot exist without the Bruch's membrane. So the Bruch's membrane can never end before the choriocapillaries end. So these are the two configurations of the Bruch's membrane which we have seen previously. I would want you to note the choriocapillaries here. Whatever configuration the patient may present with, the choriocapillaries ends and then only the Bruch's membrane end, or rather the Bruch's membrane can never end without the choriocapillaries ending. So that is the key here. So once you trace the choriocapillaries, this green zone here, the green zone here depicted is the choroid. So this green zone is the choriocapillaries. So mark the choriocapillaries, and once it has ended, you will see the red dot of the Bruch's membrane opening adjacent to it. So that's how we find the Bruch's membrane opening to start with. Sometimes if there is a major vessel, as you can see here, this reflection here, which is shown by the red arrow, there is a blood vessel which may obscure the Bruch's membrane opening here. Sometimes a simple adjustment of the contrast in the machine will help us in identifying the Bruch's membrane opening. So this is an animation of Bruch's membrane opening minimum rim width. So we have already seen what is Bruch's membrane opening, and the Bruch's membrane opening minimum rim width is nothing but it is a minimal distance present between the internal limiting membrane and the BMO, that is the Bruch's membrane opening. So you can see this is the internal limiting membrane and this is the Bruch's membrane. The distance between it, that is the minimum distance between it, is taken as the Bruch's membrane opening minimum rim width. So the Bruch's membrane opening minimum rim width is more like the renioretinal rim, which follows the ISNT rule. So the inferior and superior poles will be slightly thicker, as you can see by this black line, which is kind of like a double ump pattern, where you can see this is the inferior part and this is the superior part, which is thicker than the nasal, as you can see here, and then followed by the temporal, which will be talked in the next speakers will be speaking more about it elaborately. And this is one of the German series that I watched recently. Germans keep coming up with so much of astonishing things like this kind of a series, Dark, which says that every decision for something is a decision against something else. So what BMO MRW, that is Bruch's membrane opening minimum rim width, has put an end is the Bruch's membrane opening horizontal rim width. So previously what we used to do is we used to measure the horizontal plane, that is the BMO horizontal rim width. So the distance from the BMO here to here. Whereas now what happened is there is a complete change in the basics of measuring the BMO MRW, minimum rim width, from here to here. That is the minimum rim width. So how do we go about it? So that when I see the review of literature, this is what it says. The BMO MRW, minimum rim width, yields a higher diagnostic performance than the horizontal rim width. As well as the sensitivity of the BMO minimal rim width is much better compared with the retinal nerve fiber layer as shown as blue, and compared with the red, which is the Bruch's membrane opening horizontal rim width. So definitely we are on the right track going on with the Bruch's membrane opening minimal rim width. And this is another study which showed the amount of neuroretinal rim tissue in glaucoma. So this study, what it said was the mean deviation of visual fields correlated better with the Bruch's membrane opening minimum rim width, as you can see by the crowding here, when it compared the deviation of visual fields with horizontal rim width. Also, the retinal nerve fiber layers correlated better with the minimum rim width as seen here compared with the horizontal rim width. So Bruch's membrane opening minimum rim width, we are on the right track provided by the GMPE, the Glaucoma Module Premium Edition. But the curse of the optic nerve is the variability of the optic nerve, because there are many different sizes of the optic disc. That is really a curse, because the there is a different size, so there is a different area of the optic disc which influences the neuroretinal rim. Imagine a larger disc and a small disc having the same neuroretinal rim. So on the left hand side we can see a large disc, on the right hand side we can see a small disc. Both have the same amount of neuroretinal rim area. But if you see the neuroretinal rim width, on the left hand side the large disc will have a small BMO MRW, minimum rim width, whereas on the right hand side the small disc will have a large BMO MRW. That will definitely influence the readings, where the disc size, as you can see, influences the minimum rim width. So practically, anatomical point of view, if we are dealing with a small disc as depicted here as micropapillae, we should always consider that they will be on the higher end of the spectrum, as seen by the dotted lines here. If at all they present slightly lesser than this particular spectrum, if they present themselves, for example, in the MRW mean profile, that means there is something wrong in the small disc patients. And similarly, in the macropapillae group, they may always present in the lower end spectrum. So all these permutations and combinations must be kept in mind while evaluating their patients' BMO MRW. So the anatomy makes a huge impact in it. Another variability of the optic nerve is it's completely variable. Everyone will have a different optic nerve. Some will have a peripapillary atrophy. Myopics may present up with a different kind of conus temporalis. So how are we going to categorize the optic nerve? Ideally, the ideal situation is the Bruch's membrane opening will match the clinical disc margin. So what happens when this kind of a situation exists are there will be no hyperfluorescence surrounding the rim. Here you can see both are the same margins, the true margin as well as the clinical margin. So there is no hyperreflectance. But what happens when there is hyperreflectance, like in conditions like peripapillary atrophy or conus temporalis? So how are we going to categorize these situations is the challenge. The peripapillary atrophy, conus temporalis, and adding fire to the fuel to fire, the peripapillary atrophy mixed with the conus temporalis. So this is, so now we have to see the basics of how we are going to divide these zones. So this is a small slide which takes into the concepts of alpha zone, beta zone, and gamma zone so that we can understand the concepts much better. So what is an alpha zone? So you can see here, the alpha zone is nothing but the Bruch's membrane is present with an irregular RPE. So as you can see here, the RPE is always on top of Bruch's membrane and then followed by the sclera. So here the RPE comes and here it becomes irregular. This area the RPE is irregular, followed by a Bruch's membrane which is present. This is an alpha zone. Then the RPE ends exactly at the end of the alpha zone. Then in the beta zone, there is only BM, that is the Bruch's membrane. There is no RPE, that is the beta zone. Then in the gamma zone, there is no Bruch's membrane, no RPE, that is retinal pigment epithelium. There is only sclera here in the gamma zone. So now in peripapillary atrophy, how do the patients present? So just see on the right hand side top of the screen, the RPE ends, as you can see the figure down, you can just correlate the above box diagram with the below picture. The RPE ends very early compared to the Bruch's membrane, choroid and sclera. The Bruch's membrane, choroid and sclera end together a little later. So what happens when the RPE ends very early is that it exposes the Bruch's membrane, choroid and sclera. So the hyperreflectance is because of that, because of the lack of RPE on the above. So you can see the clear hyperreflectance in this picture, the clinical picture as well as the OCT picture. And what is the zone here? Here we can see an alpha zone. As you can see, the alpha zone is an irregular RPE with the Bruch's membrane below. And then you have a beta zone, which is nothing but the Bruch's membrane opening here. And where is the BMO located? The BMO is here, which is present at the inner edge of the zone beta. How do we categorize a conus temporalis? Again, just look on right hand side top of your screen where there is a box diagram. Here what happens is in conus temporalis, that is seen in myopic patients, the RPE, Bruch's membrane and choroid, they all end together, but before they go and join the sclera. So the sclera slightly extends further. So now what happens is because the sclera is exposed, that gives an hyperreflectile profile. So this point, yellow arrow here, that is where the RPE and Bruch's membrane end together, and the hyperreflectant area is only the sclera. So that is nothing but the gamma zone. As you can see by these two lines shown here, the blue lines here, this is the gamma zone where the bare sclera is exposed. Here the Bruch's membrane is located at the outer edge of gamma zone. How do we categorize when conus temporalis is present along with a peripapillary atrophy? So again, just look on to the right hand side top of your screen. The RPE ends much earlier than the Bruch's membrane choroid, which ends much earlier than the sclera. So this is a totally different combination where the RPE, as you can see in this OCT picture, yellow arrow is where the RPE ends, and then you see the red dot where the Bruch's membrane opening is there, which ends there, and then we see the sclera ending. Here we can see all the three zones, where there is an alpha zone, where there is a beta zone, where the Bruch membrane is only present, where there is no RPE, and then there is a gamma zone where there is only sclera. Here, the Bruch's membrane is present between the retinal pigment epithelium ending, between its ending and between the scleral ending, as shown in the box diagram here, and as also seen in the OCT below. Moving on to the relevance of the cornea. Sometimes it's very easy to ignore the role of cornea. It's a simple entry that we need to make when we examine the patients, because a mere corneal curvature may alter the way of how the optic nerve may appear to the patient. It is very important in follow-up, especially when you are doing following for the same patient. So this is the same patient when the corneal curvature was entered as 6.2 and when the corneal curvature was entered as 9.2. You can see how much of an impact it made on the BMO area. On the left hand side it is 1.43, whereas on the right hand side it is 2.01. It is just mere diffraction where the corneal curvature makes a difference in the BMO area. The applied anatomy points which we need to keep in mind is, make sure the segmentation is done properly. On the right hand side you can see there is an improper segmentation. It will always be given up by the jagged profile of the BMO MRW. And always in the Bruch's membrane opening, we can always mark the Bruch's membrane opening manually by using the neighboring point as an advantage. So in this right example, we can see the Bruch's membrane opening is not present here. How do we go about marking it? So what do we do? Just make sure you go to the next line diagram. So this line is what is under examination. Go to the next line. So see this image, we have just gone to the next line. And now we have picked up the BM in that area, Bruch's membrane opening, mark it and bring the green arrow to that area. We have now brought it. Now go back to the previous plane, you get the BM in that area. So marking the Bruch's membrane opening is very important in an anatomical point of view, so that we give the right amount of quality to the patient. And this was the last minute induction of topic of the macular anatomy, which Sathyan wanted me to cover. So just few points regarding the anatomy and we are done with, which Sir will be covering in his posterior pole asymmetric analysis. So glaucoma pathway, we all know that it is because of increased IOP, that is antegrade, where the increased IOP may cause damage to the optic nerve, or it is because of a problem in the lateral geniculate body, which may send a retrograde transport mechanism and cause a damage. But whatever it is, retinal ganglion cells are very important, because the retinal nerve fiber layer arises from the retinal ganglion cells, as we have seen in the previous pictures, and the retinal ganglion cells relays itself to the lateral geniculate body in the cortex. Why macula? Macula is surrounded by abundant of retinal ganglion cells, which is 50%, more than 50% as per Curcio and Allen et al. It is a multi-layered ganglion cells which are present surrounding the macula. With the help of Spectralis, we get 61 OCT scan lines which segments all the layers of the retina. With Spectralis, the segmentation is so meticulate that we can differentiate all the different layers of retina as shown in the right hand side. Every different layer is independently acquired, whereas before this technology, this is how it looked. We were not able to segment every individual layer of retina, whereas it was more like a regional segmentation. We were not able to get the individual structures per se. So with the help of that, the macular segmentation was done with ease and it was interpreted. This is a normal picture showing the ganglion cell layer as in the C diagram here. This is the ganglion cell layer of normal patient. When there is glaucoma, you see that there is a loss of tissue, which will be covered by the forthcoming speakers. This is an important grid called the Garvey-Heath grid from an anatomical point of view. This is a 6-sector grid which has been positioned in such a way that it gives only data regarding ganglion cell layer, and this grid will be of no use in retinal nerve fiber layer color-coded classification chart. So the summary or take-home point is, whenever we see an optic disc from an anatomical point of view, because of the 24 scan lines, we have 48 BMO positions. Pay attention to it and then get the Bruch's membrane opening minimum rim width, either by means of a color-coded map or you get it in a 2-dimensional display profile. Once we get the Bruch's membrane rim as seen in this chart, then we'll have the subsequent RNFL followed by different segmentation where you have the loss of RNFL here and then followed by GCL. This is a classical case of an inferior temporal notch glaucoma patient where inferior temporal notch rim is absent there, RNFL is absent, there is an inferior RNFL loss, and subsequently the ganglion cell layer is also affected. More examples will be seen by forthcoming speakers. So this is just the last slide of my presentation where Bruch's membrane opening is going to be a game changer, or is it always a game changer now, especially with the minimum rim width. So in that example where there was a constriction of the inferior temporal notch as shown only in this graph, where we get 48 different scans. So I'd like to thank once again my mentor, Dr. Sathyan sir, and I would also like to thank Heidelberg Engineering for giving me this opportunity. If you are able to understand this picture, that will be more than sufficing of what it is. This is all about covering this particular anatomy of optic nerve. Thank you.
Thank you, Prasanna. It's a wonderful presentation. Friends, it is really essential and very important to understand anatomy before we go through the next steps. Otherwise, we will be lost in what we are looking at. Anything anatomy is going to be really important. So let's look at, once anatomy is understood, let's look at what is the technology that is involved in the Spectralis, which is a little different from all the other machines. Why Spectralis is so special? Mr. Martin, may I have your presentation? We'll have all the questions answered in the last. Prasanna, you can go to the stop sharing. The top, you got it, yeah, wonderful. Good evening, Mr. Martin. Nice to have you in this meeting, and over to you.
Thank you very much, Dr. Sathyan. And I would like to thank Dr. Venkatesh, which is for a fantastic presentation. It's one of the best presentations I have seen explaining how the anatomy of the optic nerve head can be applied with OCT technology. It was a really, really superb presentation. Thank you. So let's talk about how the technology works behind the software to help you in a clinical environment to better diagnose your glaucoma patients. What is our glaucoma DNA? Well, the first point is that we have something called confocal optics in the camera, which is a little known secret. And confocal optics gives us image quality. You can see the quality of our optic nerve head image here on the left-hand side with our Spectralis compared to one of our friendly competitor. You can see in a color fundus camera what is the difference between a confocal multicolor image compared to a fundus camera. It's almost like a three-dimensional image compared to a two-dimensional image. And this is really visually try to describe what the difference is between confocality and normal fundus camera. And if you look at fundus picture, you see much more structural detail in a confocal multicolor picture. It helps with small pupils because we don't capture scattered light. We can go into small pupils, and other devices you may not even be able to see the optic nerve head, whereas with a Spectralis you can actually see the optic nerve head and make an evaluation. It's also much better with cataract. We avoid all the light scatter caused by cataract, and you'll notice that on the right hand side there, this is a fundus camera picture, and it's completely flared out with the light scatter from the cataract, whereas we can actually see the fundus with our confocal optics on the Spectralis. Why are the images so clear? Well, confocal optics eliminate light scatter and they increase the contrast. And this is the key. Increasing the contrast provides much better resolution, and look at the difference in the structural detail that you can see on the left-hand side of a Spectralis image compared to a traditional fundus camera image. But this is just the start. Our DNA thread runs through everything that we do relative to retina and certainly relative to glaucoma. We have live eye tracking almost since the beginning of the development of Spectralis, and that gives us reproducibility. If you don't track the eye properly, you are always chasing the fundus with your OCT. What we do is we lock the two light beams together, so we always know where the OCT is relative to the fundus or relative to the optic nerve head. We sample 16 circle scans. If we do a nerve fiber layer circle scan, for example, we have to match every circle to each other. If they don't match, we throw away the data that doesn't match. This is not like software tracking. Every device says we have tracking. Do you really have tracking? Let's prove it, and let's see how reproducible are your eyes when you do a follow-up. It gives us a 1 micron reproducibility. The average nerve fiber layer or a ganglion cell complex or GC-IPL thickness in glaucoma suspects is both about 80 to 100 microns. That's what we're looking to try to assess. Your Spectralis has a detectable change, let's say 1 to 2 microns to be conservative. Some OCTs have only a reproducibility of 8 to 10 micron. And so the variability of 8 to 10 microns is 10% actually of the tissue you're trying to measure. So in fact, the disease change is masked by the instrument variability. You only can detect glaucoma if your instrument is good enough. You cannot see nerve fiber or ganglion cell complex, ganglion cell inner plexiform layer damage at a level of 8 to 10 microns reproducibility. Or if you can see it, it's very much later in the disease process. We have art, something called the art of OCT. This is automatic real-time meaning of the image. You may know it as averaging. The OCT signal measured in tissue is typically quite low, particularly in the case of disease. So if we capture the exact same area multiple times, this allows for a much more effective discrimination of random noise from true tissue signal. And so our images have better contrast and detail. So if you look here, this is a single grainy OCT scan compared to a scan which is an average of 100 scans. And look at the difference in the quality of the image, and you actually can see the layers, and therefore you can segment much better the different layers of the retina, including the individual ganglion cell layer. If you look at circle scans on nerve fiber layer on OCT, you'll notice maybe that most of the devices are doing a cube scan, and they take the circle out of the cube. And so you're only looking at an ART1 scan, which is a single OCT scan. What we have on our Spectralis is a dedicated circle scan. It's not coming from the cube. And we have the possibility to automatically capture 100 averaging in our nerve fiber layer scan. And you see the difference in quality of the image. Okay, so we have a dedicated circle scan. Other companies are doing a cube scan across the optic nerve, and then they're taking the circle scan out of the cube. And it means that you have a third of the data points compared to a dedicated circle scan. And that means you have a much less sensitive ability to identify small focal nerve fiber defects. So this is a real critical differential point if you're looking on nerve fiber layer. Now, because of our eye tracking, we can do something called full raster averaging. And that means averaging of all the B scans or rasters within a volume scan. What you may notice on other devices, they only can do a single scan on every single B scan. And so therefore the quality again of the image is much higher. Confocal optics, live eye tracking, the art of OCT averaging, if you like, and full raster averaging, that's art within a cube scan, all synchronized together. This is part of our DNA. And we synthesize, and it gives us a better segmentation. In fact, I call it synthesized segmentation. We can segment all 10 layers of the retina, and we can measure the ganglion cell layer and the inner plexiform layer separately, whereas other OCTs combine them and form a complex, so-called GCC or GCIPL. What happens if the ganglion cell layer thins and there's a reaction to the inner plexiform layer and it thickens? If you measure both layers together, you might mask these different effects. So it is better to see the effect on each individual layer in glaucoma. We look on the inner retina layers. We look on the retinal nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. So which type of OCT is best for glaucoma? I'm often asked. What about swept source? Well, swept source has a longer wavelength, but the longer wavelength provides less contrast between the inner retina layers compared to the shorter wavelength of spectral domain OCT. So this is just a principle of physics. So between the ganglion cell layer and the inner plexiform layer, if you use swept source OCT, you're going to get about 8% contrast difference. But if you use spectral domain OCT, you get a 20% contrast difference. And so using swept source OCT may in fact lead to difficulties when you try to segment these two layers. And that's what we want to look on in glaucoma. So for segmentation of inner retina layers, actually, spectral domain has 2.5 times the contrast of swept source. And we can talk about other factors relating to the comparison if you want to at the end of the presentations. What does this mean for us? It means that we're going to have better segmentation, and that means we're going to have accuracy. Finally, the last DNA component, very important for glaucoma, we have auto rescan. This gives us clinical confidence. Our live eye tracking allows us to exactly align follow-up scans to the baseline. And then we have continuous live eye tracking when we do the follow-up scan on top of this. And that gives us accurate progression. It gives us accurate diagnosis as a result of that, and of course, accurate treatment and accurate patient management. And this should give you greater clinical confidence if you trust that you have a good OCT working to help you. Now in glaucoma, you must come back to the same small piece of tissue to confirm change. Probably these days, clinically significant change of nerve fiber layer is about 4 to 6 microns. So with your Spectralis, you have a detectable change at level of 1 to 2 microns. And this is possible because of Spectralis live eye tracking. It's actually the live eye tracking that allows you to confirm the progression accurately and therefore help you to diagnose glaucoma. If you don't know today, you have a suspect patient, you're going to confirm whether or not they're glaucoma on the basis of progression, either by visual field or, if you believe and trust on your OCT, by OCT structural measure. Some numbers. Glaucoma patients lose 2 microns of nerve fiber layer per year. So I say Spectralis probably could confirm whether you have a progression in 18 months, let's say 2 years at the outside. And some OCTs may take 4 to 5 years or even longer to do the same thing. So the bottom line in using OCT clinically is, if it was your mum, do you want to know in 18 months to 2 years, or do you want to wait 4 to 5 years, by which time she may have developed visual field loss? And that's really what we're talking about. What are the benefits of GMPE? You have anatomic positioning. Dr. Venkatesh already talked very nicely about the optic nerve head, and we've discovered every single eye has a different angle from the fovea to the center of the disc, and the range could be at least 20 degrees. So if I set my patient to +2 and then switch them to -18 degrees, you can see that the profile of the nerve fiber layer changes against the normative database. And so you can change the sectoral analysis and the classification of your patient just because you haven't properly fixed the orientation of the eye. This would be called so-called red eye disease. None of the OCTs are doing this. So this is one of the main benefits that you have with your GMPE software, that we have a proper evaluation according to the individual eye. So we automatically identify where the fovea is from the beginning. Then we go to the optic nerve and we look at 4 primary points of Bruch's membrane opening, and we center the disc according to those primary points. And then we fix the angle of every individual eye from the fovea to the center of the disc according to the anatomic disc margin Bruch's membrane opening. This is before we do any scanning at all. And then we start to scan. We do a radial scan to look at the neuroretinal rim. We do circle scan for the peripapillary nerve fiber layer, and then we scan the whole of the macular area where we can segment the ganglion cell layer and look around the fovea. This means you have anatomically individualized scans and analysis. All eyes are normalized to each other, and this matches the configuration of your axon. So it doesn't matter if you have a horizontal orientation or an angular orientation, everybody is starting at the same anatomical point. So this is a good start point if you want to analyze glaucoma. So we use anatomic positioning together with our live eye tracking, and you can see how I ask the patient to move their eye, and we're tracking live the patient and making sure that anatomically we are correct in our evaluation of our nerve fiber and our posterior pole ganglion cell configuration. This is how it works in a live situation. So we align to the retina, first of all, and then we switch to the optic nerve, and we identify automatically where the fovea is. You click on Start Fovea Detection, wait for the blue bars to complete, and then you can confirm your fovea position. Then we move to the optic nerve and we look for 4 primary points of Bruch's membrane opening. We start Bruch's membrane's opening detection, and then we confirm. And now we're ready to scan. So here we go, get our optic nerve in the right position there in the hot spot of the OCT, up here, nice and clear, and now we're ready to start our radial scan. And we're doing ARC 25 for all of the 24 radial scans in the program. So this is a very comprehensive analysis of the optic nerve head. So every scan, 25 ARC to get a better contrast and detail, and that helps us with a much more accurate segmentation. So we do the radial scan, and then we do 3 circle scans. One at 3.5 millimeter, which is a common one, 4.1 and 4.5. And I can explain to you afterwards if you want to know what the difference is and why we're doing 3. So that's how it works. And we get good image quality. I have a friend, Christopher Lee, who worked for 10 years with Professor Harry Quigley in Baltimore. And Harry Quigley is one of the gurus of glaucoma, I'm sure you know. He says image quality is everything. The things that make Spectralis wanted by the retina clinician are the same for diagnosing and monitoring progression in the glaucoma practice. Look at the quality of these structural scans, confocal multicolor here, and infrared. You can actually see the disc because it's a reflectance image. You can see the neuroretinal rim because it's a reflectance image. You can see the configuration of the vessel trunk, and this is important when we start to talk about the evaluation of nerve fiber layer scans. And even you can see very nicely focal nerve fiber defects because of the quality of this structural scan. You can see the whole anatomy, if you like, with OCT of the optic nerve head. And physically, we can see the actual nerve fiber layer tissue, and we can see whether it's segmented properly or not. So this is very helpful. If you know what you're looking on, you can make observations just looking on this. we can see here that we've got a little bit of a problem with our nerve fiber. And this is going to not help us when we're trying to evaluate from a glaucoma perspective what's happening with the patient. And we've got a missegmentation as well. So you can correct these things, but you can see it. On other OCTs, you don't see that you have a problem to start with. So this is very important looking on the image. You can see that you've got a segmentation error here and you can correct it. In this case, you can look to see in detail what happened. And this is the most common error in OCT. You get a clipping of the nerve fiber layer if your technician is too close to the eye. So we need to make sure that our technicians know what is important in imaging with OCT for glaucoma. This is the most common error. We take a holistic approach. Are you seeing the whole elephant or are you only seeing the front? We have technology to match pathology. So we do a radial scan around the neuroretinal rim. We identify the inner limiting membrane and we identify Bruch's membrane opening, which should be the true anatomical disc margin. And from there, Bruch's membrane opening to the ILM, we measure the minimum amount of rim tissue that the patient has, the worst case scenario for the patient. From there, step 2, we go to the peripapillary nerve fiber and we can evaluate the thickness and the profile of the nerve fiber layer as well. And finally, we finish up step 3 with a macular scan. We call it posterior pole across the whole of the macular area. And we look at retinal thickness maps and we can segment the nerve fiber layer and also the ganglion cell layer. And it's the culmination of all of these things together which actually gives us confidence with our clinical diagnosis. We don't look at one thing only, just the nerve fiber layer. We look at several things to make our clinical assessment, and that gives us more confidence. We take a holistic approach. Glaucoma's a multifactorial disease, and so we need a multifactorial solution. And Chris says glaucoma is not just a disease of the optic nerve, it's a disease that affects the layers of the retina, and we image them better than anybody. We give you, if you like, clinicians, 4 distinct pieces of data that can point to the glaucoma status of a patient. So we give you the neuroretinal rim, Bruch's membrane, minimum rim width, the retinal nerve fiber layer, full retina and asymmetry with the posterior pole, and the ganglion cell layer. It's like 4 pieces of jigsaw, or if you are spiritual, it's mind, body, soul, spirit. And now we added deviation maps as well. You can discriminate. Have you got normal goldfish, let's say normal patients, or have you got blue or green fish? Are they glaucoma or are they some other optic neuropathy? So we can discriminate, I think, glaucoma from physiologic eyes and other optic neuropathies. This is where I think some of the power comes to help you in the clinic. We can give you the ability to make a qualitative and a quantitative assessment of the optic nerve, as well as the nerve fiber layer and the ganglion cell layer. And most clinicians don't take advantage of all the information that's available to them. And this can be the key to finding glaucomatous damage or discriminating between healthy and diseased eyes or other optic neuropathies. Just look at the different patterns of damage that you see in a retina thickness map between normal compared to glaucoma. You can see probably not much difference in these early glaucomas, but if you look in the detail, you will discover that there are notching across the horizontal midline of the ganglion cell. And I can show you how to look on that later if you want. In moderate glaucoma, you're going to lose half a hemifield of your ganglion cell, either superior or more likely inferior is more common. Here are 2 brothers with a family history, and you can see the older brother looks relatively normal, but the younger brother for sure has a structural glaucoma problem in his left eye. Look at advanced glaucoma where you've got very thin looking retina and ganglion cell. Here you have to be a little bit careful because you may have another optic neuropathy present, so-called somaropathy, which looks similar to advanced glaucoma. So we have to look at more detail and other things. You can look at horizontal loss compared to vertical loss. You see different patterns from chiasmic to post-chiasmic patients. And you see differences in myopic to simple optic atrophy and microcystic changes in papillary macular thinning. So look at the patterns of damage, and that may give you some indication whether you've got a glaucoma model or have I got something else going on. This is going to give you clinical confidence. You can do it. The repeatability of the scans and live eye tracking give you more information, and the information that you got is accurate. And as a clinician, you're going to have greater clinical confidence in diagnosis and management of your patients. We do a systematic evaluation. So we look from the neuroretinal rim, step 1, we go to step 2 to the nerve fiber layer, and then we follow the axon and we look on the ganglion cell layer here. Okay. If I look on a full retinal thickness map, I can see a focal nerve fiber defect. It's like a river going to the lake, and I can see the associated notching of the ganglion cell here already. And if I segment the ganglion cell layer here, I can see much clearer the segmentation and the notching of the ganglion cell layer. This should be typically a ring of ganglion cell layer thickness, an average of about 50 microns. Here you can see 25 versus 46. So I'm looking all the time for asymmetry in glaucoma. I'm looking for hemifield asymmetry between the upper and lower within the eye, and I'm looking for asymmetry between the eyes as an indication of glaucoma. And typically you're going to see on the temporal side of the ganglion cell layer, here, and you're going to see an imbalance across that temporal side of the ganglion cell layer. This patient, if they're normal, should be 46 to 50 compared to 46 to 50. And here we have a massive difference, 21 micron difference, as an indication that this is an early model of glaucoma. And just as a clinical guide, I take 10% variance here as a first indication of maybe some early changes. So if this patient had 46 here and had 40, 39, 38, I start to think maybe there's an early glaucoma notching of ganglion cell, and I look for a correlation on the nerve fiber, and I look to the neuroretinal rim to see if there's an indication that an agreement, if you like, with these other parameters. It always happens across the horizontal midline. So you see a pattern like a snail shell. Let's finish up with a case. This is a 62-year-old lady presenting with open angle glaucoma. She's got some indications in her disc photography, and she's got some indications in her visual fields, both 24-2 and 10-2. If we look at the fundus images, you might just see a nerve fiber defect in the fundus image, but for sure you can see it very clearly in the confocal multicolor and of course in the infrared as well. Here are visual fields. We can see evidence of an early nasal step here and also some superior pattern standard deviation defect on the visual field, and in 10-2 the similar superior hemifield loss in 10-2. If we go from the rim, I can see a depression here that I don't like. And I look at patterns of damage. I look at the profile of the nerve fiber layer rather than the sector analysis. And this patient should follow the green midline here, and they've got a massive area here which is depressed. So I don't like the look of that. If I look on the nerve fiber layer, I've got a similar large chunk out of my temporal inferior nerve fiber layer, and that correlates with what we have seen on the rim. If I go to the posterior pole, I see that focal nerve fiber defect, and I see the notching of ganglion cell. And we use the principle of asymmetry, just like glaucoma hemifield test in visual fields. Have I got an imbalance between the upper and lower hemifield? And I've got an obvious imbalance here in terms of thickness. These black boxes tell me that this is at least 30 microns thinner than the corresponding location in the upper hemifield. And if we look to the ganglion cell layer, that's the same example that I showed you, and you can see that notching of the ganglion cell layer across the horizontal midline. If we go to deviation maps, we can see that focal defect on the full thickness map And then on the full retina, we can see that nerve fiber defect coming from the optic nerve. If we look on the nerve fiber, we can see even clearer the defect in the thickness map. And on the deviation map, you see what the extent of the damage is compared to normal. So it's much more obvious in the deviation map when you look on that. And if we go to the ganglion cell layer, we can see that notching effect and look at the extent of the loss of ganglion cell layer, let's say, compared to normal. And I've been thinking that we just looking across here at the temporal area of the ganglion cell, but in fact, it extends right out here when you look on the deviation map. So I find it very useful. Additional information, if you like. And we can look on the inner plexiform layer. I don't look on it so much because the ganglion cell layer is really probably the most important thing. So you can flip between the nerve fiber layer and the ganglion cell layer. I have a progression case, but I think I've run out of time. So maybe I should stop here and pass the ball to our next good speaker. So thank you very much indeed for listening.
Mr. Martin, thank you so much for explaining the technology in detail and also covering up my topic as well.
Sorry.
No problem, no problem. Anyway, we can always do that. Without any much of a delay, because we are running out of time, because we'll have Dr. Harsha. Harsha, can you just share your screen? Harsha is going to talk to us about the important measurements on the Bruch membrane opening and regarding the optic nerve analysis in Spectralis. Over to you, Harsha.
I hope I'm audible. Well,
yes,
I'll not take much of the time because, as Dr. Sathyan said, most of what I'll be speaking was already being dealt with both by Dr. Prasanna and Martin. So I'll quickly run through them, just more like a revision. I don't have any financial interest related to whatever I'm speaking today. So Dr. Prasanna told to us already how do we examine the optic disc clinically in glaucoma. So we don't take a lot of information into account. We look at the disc margin, which is defined by the inner edge of the white scleral ring as shown here. And the cup is taken as the level at which the neuroretinal ring steepens. And then we have the vertical cup and the disc diameter there, and vertical cup to disc ratio is the most popular parameter which we use for evaluating the optic disc. So most of these materials have been taken from the educative material on the Heidelberg website, and we've already seen this. Dr. Prasanna has shown this also. So I would just like to summarize here once again and say that the disc margin, which we see clinically, is a very inconsistent anatomical landmark for the outer border of the neuroretinal rim. So the neuroretinal rim can extend well beyond the scleral ring or can be much inside of it, making our assessment fallacious. So how does optic nerve head, how is optic nerve head segmented and analyzed on OCT? So if you look at, if you think about time domain OCTs, or even if you look at, say, the Avanti OCT, some of the earlier versions of OCT, the segmentation of optic nerve head used to happen in a different way. On the Avanti here, there were two planes marked. The first one was the plane connecting the RPE tips, the lower red line here, and then another plane is demarcated, which is 150 microns above it and parallel to it. And the area or the tissue which lies between the upper plane and a perpendicular line drawn to it. So along these three yellow circles seen here, that small triangle is considered as the rim. Well, then subsequently, with the advent of better resolution OCTs, we knew that the actual landmark for the disc margin has to be the Bruch's membrane opening. So we've heard it wonderfully by Dr. Prasanna. He showed a lot of anatomical details of this. So then we realized that the Bruch's membrane opening not necessarily correlates with the clinical disc margin which we see. So if we don't account for the correct geometric orientation of this, then the rim which we are measuring either clinically or on different types of OCT devices once again can show errors, like the horizontal rim width which Dr. Prasanna once again showed to us about. So in certain eyes, the axons of the ganglion cell exit the eye almost parallel to the visual axis, and in some it can exit perpendicular. So if it enters perpendicular, you have a very shorter horizontal rim width, and if it exits more parallel, you have a longer horizontal rim width. And one may be considered abnormal compared to the other, which necessarily is not so. So nowadays, most of the OCT devices, they consider the Bruch's membrane opening as the landmark for the optic disc margin. So this is the segmentation of the Zeiss machine. So the Zeiss machine also considers the Bruch's membrane opening as the optic disc margin. The way it demarcates the rim is slightly different. So it considers a lot of vectors as shown here from the Bruch's membrane opening to the internal limiting membrane, and then constructs trapezoids at each of these vectors. And the lowest or the smallest the trapezoid is what it considers as the minimum rim area. So very similar to the minimum rim width, which we all heard about. So the Zeiss machine also estimates something called a minimum rim area. So in addition to that, there are other ways of projecting the three-dimensional image which is acquired into a two-dimensional system. So if you don't correct for the orientation of the plane on which the rim tissue is measured, like what you see here, for example, there can be a shortening of the rim falsely. So when the orientation is adjusted for, the plane of the measurement is adjusted for, then we get a good or a more appropriate representation of the rim tissues. So we've heard about how the Spectralis segments out the optic nerve head, and we've heard about what the minimum rim width is. So I wouldn't go into the details of all of these. And we've also seen this, the landmark experiments from Bal Chauhan's group, which shows that the minimum rim width has a fantastic diagnostic ability to differentiate normals from glaucoma eyes. So going on to how RNFL is segmented and analyzed by OCTs. Once again, the multiple devices segment the RNFL differently. But what I will highlight more is how the RNFL thickness is analyzed by different machines. So most of the devices, what they do is they use the cube scans, and they use the fixed horizontal and the vertical axis to analyze the RNFL thickness. Like what is seen here, there is a fixed horizontal and a fixed vertical axis along which the RNFL is analyzed. And the sectoral analysis is also reported according to these fixed axes without considering the fovea to BMO center axis. So here is the BMO center and the fovea axis. This anatomic position is very important to us, because this is how the anatomy of the retinal nerve fiber layers are. And in all human eyes, the path of these axons as they exit, they remains constant relative to the fovea to the BMO axis. Martin also showed these images, saying that there can be large variation in the fovea position relative to the BMO center, and this can vary from anything from -18 degrees to up to +2 degrees. So the Spectralis considers these anatomic positions for all its representation and the analysis of both the RNFL as well as the macular layer thickness measurements. So what happens if anatomic positions is not accounted for is shown in one of the examples here. If you look at these disc, which looks totally normal, the RNFL pattern is also normal. But if you look carefully at the pattern of the RNFL here, there is definitely a tilt to the eye. So what happens if the anatomic position is not accounted for is that there can be abnormalities shown on the reference database maps, like a thinning which is seen here in the inferior region and a suspected thinning seen here in the superior region is essentially because the eye is tilted or intorted, I would say. So that's what happens, and there can be the abnormal results which can come in. So these, once again, not accounting for the anatomic positions causes other problems on the macular maps as well. So this was what Martin was briefly alluding to. This is called the temporal step. So when you see an disproportionate macular thickness along the horizontal meridian, then you suspect there is something abnormal here. So here the superior region is thinner than the inferior macular region. Once again, this is possibly related to the anatomical position not being right. So once you retake the scan, allowing the eye to be positioned properly, I don't see that difference between the temporal regions of the macular maps. So that was a brief presentation, but I think more of a revision to whatever happened earlier. But to conclude, I would say that both the BMO's calculations and the anatomic positions are very useful techniques to avoid misinterpretations of the OCT results. They are more important when we are looking at detecting structural progression on OCTs, and this would give us greater confidence to detect progression in the structure. Thank you.
Thank you so much, Harsha, for detailed explanation on the BMO. Harsha is the major user of Zeiss, though he was using the HRT earlier, and I know how much he really appreciates the Spectralis. Hope you start using the Spectralis sooner, Harsha. Thank you so much. I'll just start my presentation, and then we'll have the next one from Sachin. So I'm just going to discuss again, once again, I want to thank Martin for covering me the topic. So first of all, asymmetry. We have seen that the technology matches the pathology in every segment, whether you take it as an optic nerve head or the RNFL or the GCL, we have the technology which really measures everything and gives you the accurate values. We know that in glaucomatous optic neuropathy, there is a loss of retinal ganglion cells and their axons, as well as the neural cells in the lateral geniculate nucleus and in the visual cortex. When you look at the glaucomatous damage, it is often there is a bundle-shaped defects, which is seen as in the primary lesion that is primarily in the optic nerve head. And there are several studies to confirm the optic nerve head is the site of early damage in glaucoma, and they support the hypothesis that axonal damage is the principal driver of the retinal ganglion cell loss. So as we have mentioned earlier, the early glaucoma changes should be shown in the lamina of the optic nerve head before the retinal nerve fiber layer or the ganglion cell damage. So that is like there is an axonal damage first, and then only the retinal ganglion cell damage occurs. So this is the order. First is in the rim, then there is a RNFL change, then there is a ganglion cell layer change. So if you look at the retinal, that is the optic nerve head, there is a thickness of about 250. Then when you take the retinal nerve fiber layer, it is about 100 microns versus the ganglion cell layer is about 50 microns. So this is the GCC, that is the ganglion cell complex, which includes the retinal nerve fiber layer, ganglion cell layer, and the inner plexiform layer. This gives a lot of importance in the glaucoma practice. As Mr. Martin was mentioning earlier, if you do not have a proper segmentation of these particular layers, then whatever measurements which you are doing is not going to be correct. So there are the scan protocols in the Spectralis identifies each layer separately. Most of the OCTs gives the ganglion cell and the inner plexiform layer together than separating it in isolation. That is the ganglion cell layer separately and the inner plexiform layer separately. These two layers makes a lot of difference. So Mr. Martin has already discussed about this. The Spectralis, the variability, the smallest measurable change which it can pick up is about 1 to 2 microns versus the other OCTs, the best OCTs can pick up about 8 to 10 microns. When you're looking at only the ganglion cell layer, then the variability becomes close to about 20% in comparison to if you can just add the GCC, that is the ganglion cell layer and the inner plexiform layer, the variability becomes about 10 to 20%. So this 10 to 20% variability is clinically very significant. That is where the live eye tracking in the Spectralis literally helps. So this is, of course, been covered by Harsha in detail, why there is an axis difference makes the scans different. If you have the different areas measured improperly, then whatever the diagnosis which you make is going to be completely in the opposite direction. So this is the anatomic position. You see this is the BMO, fovea BMO axis, and always the papillomacular bundle is here and the nerve fiber layer is here. If this is changed, then whatever the measurement which you are doing is not going to be correct one. So this is the anatomic position system in the Spectralis, which really is the major changer in the other OCTs, comparison to the other OCTs. So coming to the posterior pole asymmetry analysis, this is how the retinal ganglion cell layer and the GCL, how it is placed. This is the right eye, you can see this is the disc here, and you see the RNFL here. This is much thicker as it comes closer to the disc, and then you see the GCL becomes thicker as it goes close to the macula, that is more temporal. We all know that in glaucoma, there is always an asymmetry in its defects, the field defects, and it always follows the horizontal meridian. So the superior and the inferior, there is always a change, and there is always an asymmetric presentation in the horizontal axis. When you are looking at the posterior pole asymmetry analysis, in the Spectralis, there are two printouts which you can see, or the two ways how we can measure. One is called as the posterior pole horizontal measurement, and another is called as the posterior pole vertical measurement. The first photo shows that this is the vertical measurement and the horizontal one is this. We'll just see that why it has to be, the vertical is important again in the glaucoma practice. So mostly I'll be just discussing on the horizontal, and then we'll see why the vertical is. So this is the typical printout of the horizontal posterior pole asymmetry analysis. We will see one by one. So the posterior pole retinal map, this is the thickness map. You see these boxes. So these boxes, this is the whole thickness of the retina, full thickness retina. So the area which is covered in this box is 30 degrees into 25 degrees, and this is the volume scan of the each eye. This is essential. This is the full thickness of the retina. And these are all about 8 into 8 grids in each area. You can see the measurements are there, 250, 230, something like that. So that is the whole full retinal thickness, and each eye is given in that. And comes the asymmetry. If you are looking at the asymmetry maps, it can see here there is a OD OS asymmetry and there is a OS OD asymmetry, and there is a hemisphere asymmetry. So what is this OD-OS asymmetry is all about? Just look here, what is the difference between the right eye and the left eye, and which areas are thinner in comparison to the other eye. So the gray, as the intensity increases, that shows the depth of the damage. More the gray, or when it becomes black like this, the damage is more. Once there is a black boxes or the black squares, that indicates that there is a at least 30 micron loss, or little bit more than that also. And looking at the asymmetry, it is not only it shows the asymmetry between the eyes, it also shows what is the asymmetry within the eye. Between the superior and the inferior hemisphere is shown here. This is the superior inferior difference. Which areas, comparison to the inferior, which areas are lesser, thinner or lesser thickness, and inferiorly, it compares to the superior, which areas are thinner in the inferior area. And also, it gives the thickness map. That means how much is the superior area versus the inferior area thickness. Usually, it has to be symmetrical. If you don't see the symmetry, then obviously we understand that there is a problem which is happening over there. And I want you to just notice here, there is a X in this square, in the X here. That is mainly because the scan, if you see here, there is no retinal thickness measured here. That is mainly because the patient has moved. So even a very minimal movement, the OCT can pick up the change and it may not give you the values there. So obviously it shows that this is the artifact in that particular area. And this is the grayscale, which I've already mentioned. Once it becomes darker, it means there is more than 30 micron loss. And this is the this is called as the compressed color scales over here. Can highlight the early retinal loss that may be too small to be detected with the standard color scales. So that is the compressed color scale. So these are all the pictures, are the images which it gives you in the printout, which you can read. So this is the whole thing which I have mentioned, the asymmetry between the eyes, asymmetry within the eyes, thickness map, and the color map. This is how the photo shows. Just to recollect the whole thing, if you see this map thickness is about 200 plus, this is the full thickness retinal map. And this is the both eyes in comparison, how you can see, and this is the picture how it appears. And this is how the retinal nerve fiber layer map will appear in the scan pictures. The retinal nerve fiber layer, this is the retinal nerve fiber layer thickness, and this is how it will be appears in your printouts. And this is the ganglion cell layer. I want you to understand here, see here, this is about 40 to 50. It is variable between 35, 40 to 50 is the range, how the thickness of the ganglion cell layer is. And this is the printout for that. So each layer, we can really pick up the printouts and we can look at the asymmetry. So that's how important the posterior pole analysis is. So what we do regularly is when you really have a structural analysis done, you want to see the functional analysis of the same patient. So what we really do is either we do the Humphrey fields or we do the octopus visual fields, or whatever the visual fields machine which we have, we all do that. But what is the advantage of this particular machine is it really gives you the structure function as well. But this is not the real structure function. This is the area of damage is picked up and then it is plotted in the Humphrey pattern visual loss locations as 24-2 here. This is the hood map, which you can really appreciate. But once your patient has not done or not able to do the visual fields properly, this gives you an idea where exactly is the damage in the visual fields. So this gives an additional advantage. There is an additional information in the Spectralis on something called as a heat map. We are all used to the color maps, which is shown in the left side picture, and the right side shows the heat map. So why we really need the heat maps? The color maps are kind of limited colors we have. The heat maps is not like that. Even a very minimal change, we can show it in the gradients of the heat map. But if you have a color map, we really may not be able to show that there are not enough of colors for you to show the gradients. What happens is it will show as very high or too thin. So that's the problem with the color maps. So once you start using the heat maps, you will probably appreciate more of a heat map than the color maps. So color map, heat maps also can be given for all the layers like retina, retinal nerve fiber layer, GCL, and IPL. All the layers, it gives you the heat map separate. And of course, Martin has completely covered on the deviation maps. So deviation maps can be for the retina, can be for the retinal nerve fiber layer, and it can be for the GCL, it can be for the IPL. So each layer, we can see how much is the deviation, and also we can see there how much is the deviation in the progression as well. So the progression map also can show you the details. So this is the heat maps. And coming to the vertical, posterior pole vertical analysis, why it is important. So I want you to just see here, is the heat map per picture. One is the heat map and another is the color map. So it shows a very significantly thicker area here, but if you see this, it is not that high here. And then you just go and then see the vertical versus horizontal, how much is the difference. Very small areas are covered. Here you can see there's a large area which is being covered over here. One of the main reasons is that when you have a larger blood vessels passing over, what happens is it gives a bigger shadow over there. So that is one of the problems when you do the horizontal scans, and the vertical scans really helps to avoid that. So this is a vertical scan, how it has been done. And you can do both horizontal and vertical and see whether the retinal thickness maps are correct or is there big differences existing in that. If it is big difference, then probably we'll have to just look at more of a vertical map than assessing the horizontal map for the ganglion cell layer. Just to show you some of the other OCTs, this is the Zeiss OCT, which also shows, but as I mentioned earlier, if you don't have the BMO and the fovea axis properly aligned, and whatever measurements which you are going to do may not be the true measures, which is all like a vertical and horizontal measurements which you are going to take, which is not going to be really showing up the proper areas. So this is the, again, the comparison between the two OCT machines. So I won't take much of a time. I just would like to acknowledge Toshbro for Zoom meeting support. And also I would like to thank Heidelberg Engineering for the slide. Part of the slides have been supported by the Heidelberg Engineering. And I would like to thank both Mr. Venkatesh and Mrs. Kiran for their academic support. And the slide deck support has been done by Mrs. Rajashree. And thank you for your questions. Thank you so much. I wouldn't take much time to call upon Dr. Sachin. Sachin is from Mumbai. He is one of the longest users of the Spectralis, and he was really like excited to present his experience over 10 years with the Spectralis. Over to you, Sachin.
Thank you, sir, for the kind words. Can you see my screen?
Not yet.
Yeah?
Yes, Sachin. Go ahead.
Okay. Yeah. So basically, welcome everybody. I would just like to narrate my experience of the last 10 years of using OCT for structural imaging as well as structural progression. Okay, so I have worked both with the Spectralis OCT extensively for the past 10 years as well as the Series 5000. I have experience across both the machines, and I have also cross-compared both the platforms. So I would be just sharing a few ideas of how I thought of zeroing on the Spectralis as my machine of choice for glaucoma in a few slides, followed by case examples from the machines that I normally use. So I have no financial interest in the presentation. Yeah. So now the question asked on many foreign conferences is, why do we need OCT at all? Isn't field test and disc photo enough? Or is the OCT worth its use in glaucoma standalone or combined? For those who ask this question, I think 2020 is too late. I use OCT for structural progression. That is the state of affairs as of today. That is the technology that we have available to us. It's just that we are not looking at it. Now, if you see the EMGT trial, if you are talking about disc photo and fields, there was only a structure function correlation in 1 out of 306. Suffices to say that it cannot be used any longer for treatment and follow-up of glaucoma. As far as the repeatability of fields itself is concerned, it decreases with increase in field loss in moderate to advanced disease, and with worse thresholds, and improves with increase in stimulus size from 3 to 5. That we already know, but we are using stimulus size 3 as common. And hello?
Sachin,
Yeah, am I seen?
your slides are not shown.
Can it be seen now?
Not yet, Sachin.
I am seeing it as sharing. You are sharing the screen. Okay, can you share? And do that.
He may have to stop share and re-enter.
Can you see now?
No, sir.
Okay. Again, I share.
You may have to stop share and re-enter share.
Yeah, I am doing that. Can you see now?
And then see the questions. And Harsha, Prasanna, all of you, please see the question answers.
Can you hear me?
You can keep answering those questions.
Oh, okay. Okay. Let me have a look.
Sachin, probably if you want to
From the top.
answer few of the questions, that would be great.
Okay, shall I go from the top? Let's see.
Yeah, am I heard?
We
Yes.
can hear you, Sachin. Yeah.
Yeah,
Can you share?
can the slides be seen?
Not yet.
No.
Asymmetric glaucoma, where OCT will play a very important role. According to me, this stage of moderate glaucoma also, where the structure and function correlation will be very robust, also is an important phase where the OCT will play a role. Now, certain special requirements for imaging in glaucoma. First is that it should be reliably be expected to diagnose preperimetric disease, and it should be ideally suited for evaluation of progression of the disease. Now, very few OCTs, or other, I should say only 2 are having the wherewithal, we should say, for evaluating progression, because they should have a robust hardware to back their software. Now, ideal requirements for measuring a property in the above scenario, rather whether it be the disc, the RNF, and the macula, would be that it should be an easily measurable property, reproducible over most of the patient spectrum, and less affected by anatomical variations in disease. Also, it should be devoid of assumptions, as was the HRT and the GDX, and not needing complicated mathematics and physics for calculation. And it should be least operator and skill dependent and time efficient. When I saw through all these, and I went through the modalities that were available to me, I could find only a couple of instruments that would fit the bill. Now, machines for glaucoma imaging and progression assessment are very few. The very important criteria that I saw for them was it should have a very small axial and lateral resolution. That is, it should detect to the level of a couple of microns, because we are detecting in between the range of 120 and 45 microns. That is the physiological rim width, beyond which, once it decreases beyond 45, it is the floor effect. So we can't use the OCT anymore. So every micron is important at this level. Availability of hardware, as Martin said, the DNA is very important, which consists of image averaging, noise cancellation, and image registration, which is very important, and most of the machines don't have it. And the software for consistent measurement exactly in the same position. So this is very important aspect of a machine that you would be using for assessment of progression in glaucoma. It should also have a database provided which is applicable to the population.
Hello? Hello? Yes.
Dharwadkar,
Sachin is
Trying to
am I
reconnect.
seen?
It's,
Hello? Hello?
yes, sir.
Yeah, can it be, is the screen seen?
that the vessel pattern is not the same way. So that's why when you have the vertical map, then it gives you the thickness maps much more properly than the horizontal maps. So when you see this,
Yeah, hello. Can I be, am I
it is
seen?
not yet, Sachin.
Is the screen seen
Yeah.
now?
Yeah, Sachin, probably you may have to go to the examples little earlier because there is no time now. We have already 5:30.
Okay, okay. I shall just.
Part of it probably can share some of your.
Okay, so I will just share the examinations, how they are done. So this is a prototype map of the Spectralis. So it is very important to see once you are doing an assessment of the OCT on Spectralis, you have to see certain important indicators. First is you see the image of the infrared image here of the confocal image. There were important data points here, that is the scan circle diameter and the BMO area. This will approximately give you an idea how the MRW is going to behave on the Tisnet map. Then you have image scan quality here. Anything above 15 is acceptable, and ART, that is the image averaging. So all these indicate very satisfactory criteria, and something that you don't see in any other OCT machine is this posterior vitreous phase. So this is very, very important and very exclusive to the Spectralis OCT. You can see the attachment of the posterior hyaloid to the RNFL, which always will tell you some false positive changes that may take place in the thickness. So now, after that, what I do is I always go to this 3-in-1 map that shows the rim width, the RNFL, and the ganglion cell map in one image. So here you can see the entire length of the neuron. So there are certain maps which are there which do not show the entire neuron, including the ganglion cell like this. So I usually, after verifying the quality criteria, I would go to the next map and see all the three together once I'm satisfied with the segmentation and the image quality scores. So then you compare the rim with the RNFL with the ganglion cell. So once you do that, you have the entire neuron in front of you. And if all these three fall in line, as has been said previously, then there will be glaucomatous changes which will be suspected. If the macula or the RNFL react before the rim, then we should suspect some vascular or non-neurological cause to be a common to be a problem rather than a classical glaucoma. So that's what I call structure correlation. You see from the rim to the RNFL to the macula. Now the important points what you see in those maps are, you see interhemispheric asymmetry, you see inter-eye structural correlation, inter-eye asymmetry, and clinical correlation. These are very, very important, and you have to follow the sequential order. Otherwise, you may miss some important points in the diagnosis. Now, going to the prototype cases in different glaucomas. Now you see this is the early case or the ideal use of the OCT. Here, if you see that everything is green, once you see everything is green, you will be, resting that everything is fine with this patient. But had you suspected something clinically, you will look at the region that is exactly you're expected to see. That is the thinning of the rim in the inferotemporal region, a focal notching here, showing a focal notch or the eating away of the donut of the macula or the ganglion cell in the inferotemporal region. So once you see this, even though these two are green, you should notice that the thinning has already started taking place in this sectoral region, which is reflected in the ganglion cell map. Now I said you confirm the interhemispheric asymmetry, and I said inter-eye asymmetry. So the moment you follow this sequence, you will never miss. This is the other eye. You can see the this thickness is also different. There is no focal thinning. The Tisnet curves are okay, and there is no change in the donut. So this is how you examine prototype visual field, and you can pick up glaucomatous defects early. So inter-eye asymmetry, 3-in-1 map, and clinical correlation is mandatory. You see pre-perimetric disease. Now this is a classical example. This is a 51-year-old male. This is the other eye of advanced glaucoma. He's on treatment, open angle glaucoma. He's an IB. It's an intelligent bureau personnel. His corneal thickness is normal. IOP on treatment was 15 on monotherapy. Now the important part in the history is the intelligence bureau personnel. He doesn't know where he is all the time. So forget about putting drops regularly. So the moment he comes to me, he puts drops. Otherwise, he may not be putting them. So what happened was 2013. This is his status. imaging criteria, segmentation perfect. 2015, clinically, the disc appears almost the same. But if you see the image, the RNFL thickness, it is changed from 94 to 79. Now, this is 100% progression on OCT. But if you see the fields, that's hardly any change. So this is a classical case of preperimetric glaucoma. And it should put an end to the argument about whether preperimetric disease exists at all. Now you see a case of established open angle glaucoma. Now here there are certain interesting features that you should see. Here you see the macular ganglion cell having a notch on both sides. But if you compare the average RNFL thickness, it is 73 and 60. So what I am trying to show here is, if you see the Tisnit curve, here you have a focal thinning of the superior pole, which is manifested as a nasal step on the right side, which is manifested as a donut here. But here you have a bipolar thinning. Now, if you have bipolar thinning, even then you are having only a focal notch here. So remember that ganglion cells are not only located in the macula, but elsewhere too. So whenever there is a bipolar thinning, you have a biaccurate scotoma, but you have only a focal notching here. So you take the entire neuron together and not individually, otherwise you will end up messing up the whole scenario. So just look here, the macula of the left hand fields do not correspond, but the nerve fiber layer does. So ganglion cell does not belong only to the macula, and 50% is outside. So please note, and this is a very, very classical correlation of structure to function. Now look at normal tension glaucoma. This is a 43-year-old female with baseline IOP of 16 and 17, systemically normal, phasing was normal, and corneal thickness was normal. Diagnosis of normal tension glaucoma, you can see how deep the field defects go because of the complete loss of ganglion cells in the hemimacula. Now, if you see here, the field defects are very close to the fixation on both sides, left more than the right. Now, if you compare the Tisnit curve, the left is more depressed than the right. Now, if you see the average is 99 and 88, almost a gross difference of ganglion average RNFL thickness. And if you see the sectoral changes, it is 62 versus 34. And if you see the field defects, they're absolutely corresponding to what we see on the imaging. So here you can see almost a hemimacular split in the vertical across the horizontal meridian, whereas here you have the shell type pattern that Martin showed us. So this is a classical case of normal tension glaucoma, and if you can see the depth of the loss of ganglion cells is much more in normal tension glaucoma than in conventional open angle glaucoma. So this is something that is very, very important. So GCL defects are very large, and that's why they are near fixation, and scotomas are huge and deep. So ultimately that female confessed to having migraine as a history, so we could correlate somehow and label it as normal tension glaucoma for sure. Now angle closure disease, because of the shutdown, I couldn't get my angle closure slide, so I'm just doing a prototype slide from the Series 5000. So here you see it's a 70-year-old patient, bilateral PACG status post angle closure attack. Now see what happens. Now here if you compare, you do have an RNFL loss, but the loss of the rim and the RNFL is not as bad as the loss of macular ganglion cells. So if you see here, the ganglion cells are completely extinguished. The segmentation criteria are good. Image quality scores are excellent. But here if you see, the macular cells are completely lost. So what this tells us is that when you have vascular incidents or incidents involving extreme high pressures for a short duration, you have a massive loss of ganglion cells, which precedes the loss of RNFL and loss at the disc margin. So this is one thing which you should remember, and this we corroborated and presented in the study at 2018 GSI, where we correlated the OCT angiogram to these findings. So this you can see very clearly, the loss of ganglion cells precedes the loss of, this is post-acute attack, mind you, not chronic angle closure glaucoma, which behaves like an open angle. Now you see this is a disc suspect. Now 15-year-old female reported as glaucoma diagnosed elsewhere. Best corrected vision was 6.6 N6. Vertical cup disc ratio was 0.7 to 0.75. So disc did look glaucomatous. This looked much better than what they appeared clinically. IOP max was 19 millimeters. In office phasing was normal. Corneal thickness was 537 and 535, and fields in octopus were normal. Imaging was done elsewhere. That was also normal. So when we examine this case very closely, you see what I told you, you follow the entire neuron. And then if you see the ganglion cells are lost much more than what was lost in the RNFL. And if you see the loss of RNFL, it is more temporal than it is in the superior and inferior temporal region. So once you see this classical pattern, it is very important for you to suspect a non-glaucomatous cause for optic neuropathy, and it turned out to be a hereditary optic neuropathy. Besides that, the other clue was the IOP being around 19 would not point to a glaucoma in a patient of 15-year-old, and this was a pressure which was a treatment naive pressure. So this important thing is to look at this pattern very carefully. Now you see the utilization of OCT in tilted disc. If you are confident of your hardware and if you are confident of your disc registration, then you can take these kind of TCAS decisions, if I may say that, say so. You see this scan is done in 2011. I am using this OCT since 2011. That time this 24 line scan was not there. This was a simple circle scan was there, but the FODI was already existing. So I was pretty confident about what I was doing. This was a 42-year-old female who presented to me with AGM for 20 years intermittently till 2011. She was using IoT. She had a tilted disc. If you can see the IR image, it has a inferior temporal thinning. Isn't rule is not respected, and there is a deep excavation of the cup. IOP was maximum 21 without treatment, and central corneal thickness was 517, 519 respectively. Now I had, because she was on intermittent treatment, I took the decision to put her off the treatment, and you see what happened. Now the latest scan is done in May 2016. If you see, you can follow up the scan, the average nerve fiber layer thickness and the profiles are absolutely superimposing, and nothing is changing. Now, how do you get this confidence? If you have the correct hardware with you, you have the confidence to put the patient off treatment and monitor her and tell her confidently that everything is normal, nothing is changing, and we can keep you off treatment and monitor you on regular imaging techniques. Now, see this another example, glaucoma versus non-glaucomatous case. The 59-year-old male.
Sachin,
Yeah.
Sachin, sorry to interrupt.
Yeah.
As the time is running short, probably with this example, can we just have the questions answered?
Yeah, sure. So this is a 59-year-old male, glaucoma, glaucoma treatment since 25 years. Current IOP at presentation was 13 on monotherapy. Maximum IOP treatment naive was 29 and 28. So he was definitely an ocular hypertensive. He was stable for 3 years on FOV and imaging. Now this was his perimetry. On the left side, you can see two baseline fields and follow-up, and you can see it's absolute straight line. There is no change. But if you see these maps, these look rank suspect. One side you have superior inferior kismet thinning, and the other side you have a horizontal change. So this is a classical bow tie pattern. Now the moment you see this, then you should suspect or smell a rat, and then that's what we did. That's why I say examine the entire neuron. The moment you do macular imaging, you will find your answer, and this is the hemimacular split. So this is a very, very classical case of neuromyelitis optica which are presented, and because of it, he had a vertical hemimacular split. So it's very important for you to see the entire nerve fiber, not only either the disc or the MRW or the RNFL or the macula, but see all the three together in one map. So this is the important takeaway, take-home message. Never forget to see all the parts of the neuron. Okay, so I'll just end by one slide, and that is by the progression side, because nobody has shown the progression slide here. We do have maps like this which give you the difference map in the ganglion cell as well as the macular thickness. That is, we call as the event analysis. But what is important here is the trend analysis, where you get the progression maps like this. You have a single baseline rather than the two which is there in the series. But if your one single map is good enough, it is good enough to compare as a single point of reference to the subsequent maps. Here also you get a rate of change, and if you can see here, you get signal outlier detected, but that outlier is nothing but progression having occurred in the first two instances. So it's very important, if you're confident of your imaging skills, the image quality and the maps, then you can definitely say that this is progression and not an outlier. So it's very important for you to understand what you're doing. Coming to the last slide, this is to show you the rate of change of thinning in one particular patient who had a peculiar problem. She was an angle closure disease. Maximum IOP in the clinic was 16. Post-PI gonio was patchy occludability for 270 degrees, and she was intolerant to all glaucoma medicines. She was a chronic unreliable patient on fields. So what we did was decided to follow her up on OCT, and if you can see here, this is the baseline at 2015. She was phakic till 2017. There was progression. If you can see, the superior temporal rim has been thinning. It is going on the downslide here, and this is the point cataract extraction was done. So the angles have opened up, and on imaging the patient is stable. So till even now the patient is not able to take any medications for glaucoma because of allergy, but just by doing a routine imaging, even though she is not good at fields, we are able to make out that she is stable and not worsening after the cataract extraction has been done. So if you have an excellent imaging tool or the DNA of the hardware is very strong, then you can confidently follow up such patients even without having a reliable field test view. So that was the moral of the story, and I think we can take questions. Thank you so much. And I would acknowledge, if you can give me 1 minute, only 2 points, sir. One is segmentation errors like this, because this is very important difference from the machines which you normally use. You cannot get segmentation error corrected in any other machines except the Spectralis. If you see the Cirrus, in Cirrus you cannot correct this error because segmentation lines cannot be changed. Segmentation lines can be changed in the Spectralis, and you can definitely adjust it yourself because the picture is so clear that you can segment with your own eyes. So although it may not be as accurate as the algorithm, but here because the algorithm has gone wrong, humans can take over and do a better job. Secondly, the changes that take place in the posterior vitreous phase, this is never seen in any other machine except the Spectralis so convincingly, except the swept source OCTs, but they suffer, as Martin said, in contrast between the individual layers because of the obvious physics. So here if you see the attachment of the vitreous are pretty clear, and here you see a case of a pre-ILM peel and a post-ILM peel, you see the profile changing completely. But here you can also make out that the vitreous is also changed, and because of which the profile has changed. Here another slide where you can see the change or the attachment of the vitreous phase changing and the profile of the RNFL changing. So these small things and these accuracies of the machine help you a lot in justifying your clinical decisions in such crunch scenarios.
6 o'clock.
Okay. So I thank Hansel for all the images he used to take for me all these years, and I think he should provide me images in the future also. Thank you so much.
Thank you so much, Sachin. I know how much you have been excited in using the Spectralis for the last 10 years. I'm sure that you have so much of an experience and you would like to share each one of that. But unfortunately, we really don't have time to share each one of your experience. But excellent presentation, Sachin. I think I'm sure that the participants would have got really benefited from each one's presentation, starting from the anatomy till what Sachin has presented. So I will take up only very few questions, which is really important. Over to you, Martin.
Thank you, Dr. Sathyan. Do we have time to answer a question, or is it better?
We'll have the questions answered. Probably we'll just take 5 minutes and then we'll close the session.
Okay. Okay.
Because people have been waiting so patiently all this time.
I know.
So,
what are the reasons for segmentation errors in Spectralis? Probably following on from Dr. Sachin. Of course, one of the problems is you could have some vitreous membrane pulling up the nerve fiber, and sometimes machines pick up on the vitreous membrane rather than the actual nerve fiber layer tissue. So this is quite a common error. And the other error, the main error, I think I pointed out in the presentation, is that sometimes the technician pushed the machine too close to the patient and you clip the top of the nerve fiber. So you must be aware of that if you're an operator, that you have to make sure that your OCT is in the correct position and not too close and clipping the top. So I hope that answers that particular question. How does the later onset of macular pathology affect follow-up glaucoma and fovea BMO axis measurement? Well, of course, there is a possibility that macular pathology can change things. And what I normally say is you can rely on the retina thickness maps, provided you don't have comorbidity. So as soon as you have disruption of the layers because of a retina condition, then you have to start to question the information that you're having on the OCT from a glaucoma perspective. So you have to use your common sense. How is that disruption of layers from the retina affecting my ability to interpret and diagnose this information from a glaucoma point of view? So you have to tread carefully, and maybe you go back to the neuroretinal rim, because the neuroretinal rim is less likely to be affected than the ganglion cell. So this is the point. Take a holistic view, look at all of the information and take the bits that make sense to that particular patient. So I hope that maybe answers an approach that you can take when you've got comorbidity. Recently, papers are showing lamina cribrosa on Spectralis with an EDI scan and ART 100. Can you please clarify? Yes, this is possible to do. Unfortunately, at the moment, we don't have any automated software to evaluate the lamina. And this is a question from people that want to do research into the changes in lamina. So hopefully that's coming. At the moment, you have to manually identify the anterior lamina and look for changes there. So it's not optimal, but of course you can get very good visualization of the lamina cribrosa with EDI, just like you can with Retina. Okay. What is a normal value for GCIPL? I think the average thickness for GCIPL, I think I mentioned in the presentation, because you're combining two layers.
Yeah.
Yeah, you're
around 80 to 100
is 50 and your iniflexiform layer about 40. So about 90 microns, I would say.
Close to about 80 to 90 or 82.
Yeah.
We don't use that in the Spectralis. We use the only ganglion cell there. We don't use the GCIPL. So.
Yes, that is the biggest advantage in this particular machine, where
we segment the GC
you can
separately.
really have the GCL separately and the IPL separately, which most of the machines cannot separate. That is the biggest advantage of the proper segmentation. Any other questions that you want to answer, or can you just send the answers? Because I think the time is really running short.
Yeah, sure.
I would just take this. Anybody wants to say something? Yeah.
Should we always do the OCT for both eyes of the patient at each visit? Yes, of course you do. Unless, of course, the patient is monocular. But I mean, you need to look on the balance between the two eyes, I think, is important. It's an important reference.
Okay, thank you. Any of the panelists wants to say something?
Dr. Sathyan, I would like to thank everybody. And we will be sending individual answers to all the team who have asked questions on the emails. So I'm sorry we do not have the time to answer every question online just now. But I thank you very much, doctors who are here today. Thank you very much for your patience, for being with us for nearly 2 hours. And I thank you, Dr. Sathyan, Dr. Prasanna, Dr. Sachin, and Dr. Harsha for being part of this event. I thank you very much. And with that, thanks from Toshbro Medicals, and we call it a day. Good evening to you, and have a good week. Thank you very much.
Thank you, Mrs.
Thank you.
I would like to thank each of the speakers for their wonderful presentations, and I wish we have more time to do the more detailed ones. So thank you so much to all the people at the Toshbro and all the participants. Thank you so much for being with us for these last 2 hours. Thank you once again.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Bye.